It's great. First of all, thanks Mahesh and Ziad for having me again. It's an amazing platform, and I really love. I hope also for the attendees you're enjoying the climate, how we are collaboratively trying to also share experiences. We're talking with some of us among us, things we are learning as we are attending these courses. So what I'm going to be talking and sharing with you today is some obviously tricks and potential experiences about reoperative minimal invasive mitrals. And I think this morning you had a very nice hint, Moritz and others stress how important to be balanced the risks and the benefits. So I'll try to obviously outline what are the different options and how we should be carefully approaching these cases. And I'm sure the very first question is that you have been listening to many presentations today about doing minimal invasive procedures, and you may wonder really, why do I really want to make my life a nightmare introducing on top of that also in a redo setting? So am I just making myself miserable? As Moritz was saying, what's my threshold where I stop and I try to go to sternotomy? But I think we should, for a second, pause and think, what's the real rationale? What are the advantages? Are we introducing more technical challenges or not? And I think a key question that was also raised I think by Mahesh this morning about the safety of minimal invasive, how actually redo minimal invasive can be considered safe. And do we really have any impact on perioperative outcomes? So if we start breaking down, I think that I'd like to start highlighting some of what I think are the key advantages of a minimal invasive approach for redo mitrals. Number one, it may seem obvious, but avoid re-sternotomy, which is not simply avoiding the same incisions and removing the wires, but I think what is very important, minimizing the pericardial dissection, because when you do a minimal invasive approach, you have a significant different amount of dissection that is required, significantly less. So it is actually, I find, extremely advantageous to perform a minimal invasive approach. And along with this, and Moritz presented a couple of very nice cases with issues in cases of prior grafts, for example. Well, when you use a minimal invasive approach, most of the times you have a chance to minimize the likelihood of damaging the grafts. Of course, you may have a patient that had a prior RCA or PDA bypasses, so you've got to be mindful of that when you're entering, not injuring that, but for sure, anything on the left side of the heart, it's basically spared. So there are, I think, quite considerable factors that are favoring a potential minimal invasive approach for redo cases. And also, unless you really want to go for a redo where you are dissecting the aorta using the cross-external, like a cheat foot clamp or detachable, and doing cardioplegia in the ascending aorta, you can really significantly minimize the cardiac dissection just to the interator groove. So again, an important advantage of the minimal invasive approach. What are the contraindications? Well, not, I would say, probably different to many of the ones that have been highlighted this morning. So when you have a considerable aortic regurgitation, severe chest deformity, or a significant underlying pulmonary disease, I would probably say these are relative vascular disease. For diffuse PVD, you may use a axillary access rather than a femoral. I tend to be cautious in patients with fibromuscular dysplasia because I'm concerned about potential risk of obviously intraoperative dissection. But I actually did operate, even with femoral cannulation, patients who had prior dissection that was after many years from the initial episode, because in that case it was stable, and I think the flap was very stable, and in fact patient actually did pretty fine. So again, it's not a complete black or white. It's, I think, more nuances that we can look into this population. Preoperative planning is obviously very important as any minimal invasive procedure, especially if we are looking at cases with prior grafts. We want to make sure we understand where we run and minimize the chances of potential injury. In terms of surgical strategy, I don't think it really matters where in your personal practice the incision is performed. I just highlighted here, some of us are using a perialveolar, some of us are using a more kind of slightly anterior incision. I personally use a more lateral, almost like an axillary incision, but it doesn't really matter. The only thing I would say in this picture that it's in general missing with a redo approach is the external clamp. And as we'll see, we have other strategies that we can use instead. So now let's start. We are in the OR. We are about to begin a case for a redo mini mitral. And what are the main challenges we may face? Well, I would say we can have two, obviously, scenarios, challenges during the lung dissection and potentially cardiac. I would say that probably, in my opinion, the lungs are the most sometimes challenging and unpredictable. The adhesions, I haven't found, at least I'm happy to hear from any of my colleagues here if they have better prediction based on CT, because I couldn't find any way to predict that. And interestingly, I also operated on patients with prior right mini thoracotomy, and it doesn't necessarily mean that you have lung adhesions. So it's truly unpredictable what you will find. But since it's unpredictable, I change a little bit the sequence when I do a redo mitrals. Normally, for first-time cases, we do at the same time the thoracotomy and the groin incision and very quickly give heparin. In this case, I want to make sure with a thoracotomy that the lung is completely dissected and fine, and I can see the pericardium before giving heparin, because obviously I would say this is something that, again, to Mahesh's point this morning about conversions, I would be, my threshold is reasonable, but I'm not going to spend the entire day doing a dissection of the lung just to prove my point that I did the surgery in a minimally invasive fashion. At some point, I'd rather convert to a sternotomy if I find that the risk of lung injury are too high, because patients may actually have pretty bad outcomes from that. I find less concerning the issue of potential pericardial adhesions, especially because, as we mentioned, the interator groove is just a very tiny portion. You just need to see a little bit of the SVC and the axis of the oblique sinus. And one thing that I do slightly different is to stay a bit closer to the phrenic nerve compared to a first-time minimally invasive mitral, especially if a patient had prior cabbages to the RCA, because sometimes you can be full, you think you are away from the bypasses, but I had a case where I basically partially injured. Luckily, nothing happened, and we didn't need to do any conversion. But my recommendation would be to stay as close to the phrenic nerve, leaving yourself obviously a few millimeters to avoid damage, but to stay a bit lower. And sometimes you're obviously at this stage on pump, being on with the heart completely empty can make the orientation a bit more challenging. So in case you don't really understand, am I still in the right, is it the left, you can leave some volume behind, and all of a sudden you can clearly understand if you are in the right spot or you need to change your dissection. In terms of myocardial protection, we obviously could theoretically use the external clamp and cardioplegia, endoballoon of ventricular fibrillation. As I mentioned, I think that probably it's less likely that you will have an external aortic clamp and cardioplegia, so the two most likely approaches are going to be ventricular fibrillation and endoballoon. I personally, I've used both, and I also ended up using more frequently the ventricular fibrillation approach. It's also an issue, unfortunately, in Canada. The intraclude is very expensive, and I have to pick my battles, and I found that it's also possible with ventricular fibrillation to have a quite reasonable approach. One detail that I wanted to share, and I'm actually, Maurice, you presented this morning, I'd like to see or hear how you also do, but we tend to think about ventricular fibrillation that we have to dissect the RV and put the lead directly epicardially. I found that it's also quite helpful to get it done at the beginning. Anesthesia puts via the right IJ a temporary pacing wire, so in this way you don't have to do any dissection at the end of the procedure. You can test even before you start the procedure if the pacing is working. And I agree that sometimes some patients may be challenging to fibrillate, but usually with a combination of hypothermia and rapid pacing, it's possible to induce. You, of course, have heard before about the interclude. So let's say very quickly for the ventricular fibrillation, very simple setup, cost-effective. Sometimes you may have issues with AI in the sense that if a patient has prior aortic prosthesis, I'll show you a case of a patient with a mechanical bantal. Sometimes the washing jets can be a bit annoying, but it's still workable. In such cases, I would say probably the interclude is an easier solution, slightly more complex setup, obviously higher cost, but it provides an ideal myocardial protection. We roughly do, my institution in our program, now more than 120 minimally invasive, and now we started since last year also robotic mitrals a year, and we now seeing an increasing number of redo cases with prior cabbages, bantals. So it's interesting to see how this is actually growing as a referral pattern. As you can see here, the section is really just limited to the interator groove, so it's also a fairly time-efficient part of the procedure. It doesn't really take many cases too much. And the left atrial exposure, especially in presence of prior aortic surgery, like aortic valve replacement, especially with mechanical prosthesis, I find that the exposure from the side, it's usually better. So that's one of the advantages of the minimal invasive approach. And this is actually how the heart and the exposure would look like in a case with ventricular fibrillation. As you can appreciate, you can barely, I would say, tell that the heart, yes, we see obviously some movement, but is not definitely too annoying. There is some back bleeding. So I would say it's a fairly workable environment despite we don't have any cardioplegic arrest. In terms of the approach, you can use whatever approach you're most comfortable with. I use a standardized non-resectional approach, meaning that I tend to use Cordex, 60 millimeters for the posterior leaflet and 23 for the anterior, and obviously the annuloplasty at the end. Despite being a redo, you can still do concomitant procedures like cryomesis. In terms of left atrial appendage management, obviously the case on the right is clearly not a redo case. So I personally have not ventured into dissecting underneath the aorta and trying to grab the appendage. So I would say that that is actually a little bit off the table. And in such cases, I do perform an internal suturing, although I agree with the conversation this morning that I'm generally a bit hesitant because of the potential risk of recanalization to do internal suturing unless strictly required. And this is an example of a patient we operated some months ago, a 71 years old patient with prior mechanical bantal, paroxysmal AFib, and P2 prolapse, otherwise mild pulmonary hypertension. So obviously the plan for this patient would be mitral valve repair, ablation, and management with the setting of a prior bantal. The question could be, is it better treated with sternotomy or MIS? And obviously we are here talking about minimal invasive, so you know what the strategy was at the end in our case. So here again you see the exposure of the interator groove and just a really minimal dissection. The again, view of the valve, it's pretty good, and as I mentioned before, our goal in this case is to use precise cords. We identify the papillary muscle, we lower the free loops, mark where the loops are going to be inserted on the valve, and then pass one limb as to complete the leaflet work. Now, in this case, we were also discussing during some of the training session, one of the issues obviously is in redo cases and you don't have an aortic vent, is air. I would say one of the advantages of the fact that you have some aortic regurgitation is that that is already filling the ventricle. So in this way, you can start testing your repair. And even in this case, you can see we are injecting, but just like minimal amount, because obviously we don't want to embolize any air. And we can have a pretty good testing, and you can see a very good result of the mitral valve repair intraoperatively, as well as the postoperative echo. So the airing is obviously something to be considered, and we need to be cautious in using quite liberally CO2 insufflation, using LV-LA venting. If you have a repair, obviously you can do the LV venting, or if you want, I personally, if there is a case of replacement, even if it's a tissue valve, especially if it's a porcine valve, I tend not to put the vent across the valve because I'm worried about damaging the leaflets. Obviously, if it's a mechanical valve, it's out of question, so you have to consider LA venting and a combination, obviously, of other tricks like Trendelenburg position. If you have a endoballoon, you're obviously more protected by having the option of using the vent from the endoballoon. In terms of what actually are the results of the experience in general from a redo sternotomy versus minimal invasive mitral, there are some meta-analyses. This is one of them. I think it was quite nice in showing like the mortality, at least the perioperative mortality appears to be, and with a caveat, there is no prospective randomized studies. These are single institutions, so it's very limited. But my point here is not necessarily to stress the fact that minimal invasive should be the option of choice and it's superior to sternotomy, but I think in terms of mortality, it shows that it's definitely safe. Actually, it seems to be significantly safer, but I would just say it's a safe option. Stroke, no difference between the two strategy. Length of stay, of course, it's in favor of the minimal invasive approach. Bleeding seems to be in favor of the minimal invasive, which makes sense for the limited dissection that you have to perform compared to the sternotomy approach. Cardiopulmonary bypass time is typically longer with the minimal invasive because obviously we go on pump while we do the dissection, unlike most of the sternotomy cases. So in conclusions, I think that minimal invasive redo mitral is a safe procedure, and now we are starting to have more tools in our toolbox to allow us to perform redo mini mitrals in a broader population of patients. Minimal invasive has some advantages over sternotomy, even trying to simplify redo mitrals. And I think with the continuous advances in standardization, we may be able to become smoother and more effective in how we perform redo mitrals compared to what for sure we were doing some years ago. Thank you again for the time.